Okay, good morning, everyone. Thanks for joining us for our community conversations. Today, our main topic is on liver issues in MTM and CNM. And I'm Erin Ward from the MTM CNM Family Connection, and I'm delighted to be co-hosting today with Ann Lennox from the Myotubular Trust and Joe Bullivant from the Myotubular and Centronuclear Myopathy Patient Registry. We're also joined today by many esteemed professionals within the community, and you'll be hearing more directly from them specifically and then learn about some efforts we're working on together as a collaborative. Next slide. So today we're going to be focusing on the liver issues in MTM and CNM, and we wanted to share from the beginning that while there is important knowledge and information to be shared today, there are also many things that are still unknown. Our goal is to share the information with the global patient community that is known, and to also share many efforts that are underway to better understand the mechanisms of myotubular and other related proteins that are yet unknown. We hope to share ways that the community is coming together to help address and expedite these efforts. And we also want to share that our focus is on learning ways to improve care for today while also helping to mitigate challenges with potential liver issues and potential therapeutic developments. And while we always at our events hope to invite the whole family to participate, we recognize that discussions today may be heavy in content, both in the presentations and also the emotion behind it. Logistically, you'll be attending today in primarily listening mode due to the virtual structure, but also we ask that you participate actively by asking questions and answers. We'll be having different Q&A sections briefly after each panel, but then also we'll be having more extensive questions at the end. We also are committed to responding to questions following the webinar that are not able to be addressed today, and also to bring to your attention that the meeting is being recorded. So this is just a high-level overview. Our part one will focus on the issues in MTM CNM with a historical overview, potential issues that are being connected to MTM CNM, and also ways you can arm yourselves with information to better follow liver issues. We'll also be talking about liver issues in the context of clinical trials, and then also how we're trying to address this as a community. We'll talk about further studies that are needed, and also a nice summary at the end, including a Q&A. But before we get started, we really want to pause and have a moment of silence for all those that have been lost to myotubular and centronuclear myopathy, but in particular, those who have passed away in the Aspiro clinical trial related to liver issues. It's important to know that we're highly committed to this area of study so that their legacies continue on and all the information that we have learned from their life experience continues. Our hearts are with not only the families of these loving individuals, but we also want to acknowledge the courage and strength that they had to participate in the first clinical trial. And many of those that are connected to our MTM CNM family community and our global community, as well as the global rare disease community. You're very familiar with our beloved Marie Wood, who is our co-founder and vice president of MTM CNM Family Connection and our dear friend. And this past Sunday, she lost her beloved son, Reed. Reed was an exceptional child with so much life and love, and we know that his love and legacy will continue on. And we are thinking of Marie, her husband, David, and Reed's siblings. So turning now to our agenda for today, and I want to also acknowledge that we're going on with this after a very difficult week in our community, but with the full support of Marie, who's attending in listening mode to support our efforts. We were ready to cancel and move it out, and she said that she wanted this to continue on, and with much encouragement, we are here today. So our first panelist is going to be Dr. Alan Beggs, obviously someone familiar to our community, who's the director of the Manton Center of Orphan Diseases and Research at Boston Children's Hospital. So I'll turn it over to Alan.
All right. Thank you so much, Erin. Could you just give me a quick thumbs up to let me know you hear me fine? Great. Okay. Next slide, I guess, Mark. So I'm going to try to be brief, but just give everybody a quick overview for how it's come to pass that we've understood there are significant liver issues in central nuclear myopathy. I'm going to talk mostly about X-linked myotubular myopathy, which was the first and the most common form of central nuclear myopathy, but a lot of this applies to other forms, including, for example, Dynamin-2 related central nuclear myopathy. And as you'll hear from our liver experts and clinicians later, there are probably some differences between these, but also some similarities. And so we're just in the process of trying to figure that out. So for this brief historical introduction, X-linked MTM was actually really first described by a neurologist, Alfred Spiro, at Children's Hospital of Philadelphia in 1966. And you see on the right here a picture of muscle fibers cut in cross-section. And those dark little dots in the center of some of these fibers represent the nucleus. Normally, those nuclei should be at the edge of the muscle fibers, but early in muscle development, they're found in the center in what's termed the myotube stage of muscle development, and hence the term myotubular myopathy, because of course, by the time a child is born, this should no longer be appearing in this early developmental stage. So for many years, the next slide, we've understood that X-linked myotubular myopathy is apparently primarily a disorder of muscle. So many of you are actually very familiar with this, but as you know, boys, and it's mostly boys since the gene is on the X chromosome and they have only one copy of that, are born often extremely floppy or hypotonic. They have generalized muscle weakness with severe respiratory involvement. So in fact, more than 90% require breathing support and feeding support very early in life. And in fact, if that's not available, then as many as 2/3 of children don't survive the first year. So fortunately, with improved medical care, especially in developed countries, the life expectancy has improved significantly. And as you all know, many of our community members have long, rich, and productive lives, but it's still quite a deadly disease. So there's quite a bit of work being done on developing therapies. You all are familiar, I think, with the Aspiro gene replacement therapy trial that has been conducted by Audentes Therapeutics, now Astellas. And there are other approaches, a number of other approaches under consideration. And I would just say for Dynamin-related central nuclear myopathy, there have also been developments, and you'll probably hear about some of those in a few minutes. The next slide. Around 1999, geneticist Gail Herman at Ohio State did a study on about 55 children with X-linked myotubular myopathy who had lived past early childhood. And essentially, she was looking for evidence that these children might have some issues with tissues or organs other than skeletal muscle. And out of this group of 55, there were a few that had this and a few that had that. There were a couple that had, for example, heart problems, but not a significant number. She did note that 6 patients had biochemical evidence of liver dysfunction. You'll hear what that means in a few minutes. And that 2 patients, in fact, died after significant liver hemorrhage, which, as it turns out, was something that we now understand is probably something called hepatic peleosis. And you'll hear quite a bit about that in a few minutes as well. In a subsequent study led by Jim Dowling in 2017, you can see here that, for example, out of, I think it was out of about 50 patients again, 49 patients, 11 had abnormal liver function tests. So they had evidence that liver enzymes were leaking out. 4 of them had what we call hepatomegaly, or big liver. 5 had jaundice, so this is where bile is not properly removed by the liver. You'll hear about that. And then 2 also had liver bleeds and hemorrhage that were probably related to hepatic peleosis. So this was the beginning of, at this point, we understood that liver issues were a problem. The hepatic pileosis was potentially life-threatening and sometimes fatal, but the other findings really were considered to be a problem, but not considered to be life-threatening. Next slide. So I'll just quickly run through a couple of other natural history studies looking at what happens to patients. And again, one that I helped lead that was sponsored by Audentes Therapeutics found that about 7% at the bottom right of patients out of about 100 had some form of hepatobiliary disorder. So this is a problem with the bile ducts. Next slide. And then in a study sponsored by Dynacure, that was a prospective where they followed 45 patients for about a year. 3 of them had cholelithiasis, which is gallstones. 4 had large livers, hepatomegaly. 3 had steatosis, fatty liver, or findings on ultrasound of the liver. And then 1 had an abnormality of the portal and hepatic vessel. So again, out of 45 patients, these were largely not life-threatening things, but things of concern that we needed to understand better. And the next slide. And then in preparation for the gene therapy studies, Audentes sponsored a trial called Inceptus, which was very similar. It was essentially following 34 children for up to 4 years to see how they did. And then some of these children, as you know, became candidates for the gene therapy. So this was, again, establishing a baseline or so-called natural history. And at the times of enrollment, actually, 1/4 of these had some evidence of hepatobiliary disease. Again, this is the bile defects that you'll hear about in a few minutes that can be characterized by jaundice and some blood measures. On a total of 91% throughout the course of the study had some form of liver involvement. And in fact, 1 sadly passed away due to bleeding of the liver caused by the hepatic pileosis. Next slide. So you're all familiar with the trial. This is a slide from a presentation that Astellas has online. And as you know, that starting in 2000, 3 of the children who had received AT132, the gene therapy for X-linked myotubular myopathy, developed fatal infections and liver that were in large part due to defects in the liver. You'll hear about that again in a little while. That trial was placed on clinical hold. These had been larger children, older children who received high doses. And so after reconsideration of the safety, the trial was started again at a lower dose. And then, as we all know, sadly, a 4th patient passed away at the end of 2020. So what you'll hear in more detail in a few minutes, largely from Dr. Mike Lawler, is how our understanding of this is evolving and how we're starting to recognize that most likely what's happened is the gene therapy has unmasked what was there all along, but was never as severe as we recognized. Last slide. Subsequent to that, or coincident with that, a study was published that, again, you'll hear about, that looked at 5 children in whom no therapy was provided, but the liver defects were quite severe, and in whom 1 child progressed to end-stage chronic liver disease. So the take-home message I'd like to leave you with here is that this remains early in life, primarily a disorder of muscle. I haven't mentioned it, but we do know that the myotubular protein is expressed throughout the body. And as we look more carefully, and also as we do things like try different therapies, we have to be mindful of the fact that there may be underlying, sometimes partly hidden defects in other organ systems. And that's really what we're focusing on today. And I think one of the end goals of today's webinar is to help raise awareness and help recruit all of you folks to help provide information through the registry so we can really understand what is the severity and what is the magnitude of liver problems in the different forms of centronuclear myopathy. So with that, I'll turn it over to Dr. Kairana. Thank you very much.
Thank you. Hello, everybody. I'm Serena Kairana, I'm a pediatric hepatologist at King's College Hospital. Thank you very much for inviting me today. It's a great honor. I will be talking a little bit more about what Alan has already mentioned in regards to the liver involvement in X-linked myotubular myopathy mostly. The next slide. Thank you. So as we've already heard, one of the problems is cholestasis, and cholestasis is essentially the impairment of bile flow, and this would manifest in the patient with jaundice, and jaundice is essentially the skin turning yellow, but where you can really differentiate its presence is by looking in the eyes and looking the white part of our eye would turn yellow. Cholestasis can also cause pruritus, which is itching, but of course itching can be a symptom of other situations as well, not just cholestasis. Alan also mentioned hepatic peliosis, and this is essentially the development of these blood-filled cysts in the liver. They would not have a symptom like too easy for us to identify, but it could be identified on scanning. Sadly, they can present with life-threatening bleeding though. Also described as steatosis, and that is the accumulation of fat droplets in the liver cells. And I just also want you to be aware of Gilbert syndrome, where the patient may still be jaundiced, but it's a different type of jaundice, which I'll explain a bit later. So it's unconjugated jaundice, and for this, the liver is actually very healthy, and there is no concurrent underlying liver disease in this situation. Next one. So just going back a little bit to explain about the liver. The liver is an organ that we have on the right upper side of our body. It's tucked underneath the rib cage on the right, and it has many important functions. It is slightly different to other organs we have in our body. So normally an organ would have blood from an artery where it will take blood with oxygen, use up this blood and the oxygen, and then you would have a venous blood coming out of the organ to go back to the heart and lungs to get oxygen again. But the liver actually receives blood from the hepatic artery to have blood with oxygen, but also the portal vein. And the portal vein will bring blood back to the liver from essentially from our whole intestine, from our intestine. So we'll bring in all the nutrients and all the potential like medications and things that we have digested. And all these substances will go first through the liver. The liver will sort them out, detoxify what needs detoxifying, and then through the hepatic veins, the blood will be distributed back to the rest of the body. But the liver also has, you can see the little green tube, the bile duct, and that's one of the jobs of the liver is to produce bile, and that would be excreted through the bile duct. Next slide. And we can see here on the left, essentially, you can see how the bile will be secreted out of the liver. It's stored in our gallbladder, and then essentially when we eat something, the gallbladder will excrete the bile into our intestine. It will mix with the food, and as our food gets digested, the bile is very important for us to absorb the fat content in our food and the vitamins that need fat to be absorbed, like for example, vitamin K. And these substances, together with the bile, will be absorbed at the end of the gut and back into the portal vein, back into the liver, and then the liver cells will need to separate again the bile acids in the bile from the various nutrients, and then use the bile acids to produce bile again. On the right side, you can see this image where you can see the where it says portal vein, it's a little branch of the portal vein running along. The slightly brown cells, you can see the brown squares are the liver cells that are lined up by the side of this vessel, absorbing the various nutrients or substances. But you can see these brown cells, which are the hepatocytes, the liver cells, also face on another side, they face other hepatocytes, and you can see this little green tube running along where essentially that is where the bile is excreted, and the bile will go into the little bile duct, from small bile ducts to bigger bile ducts, and into the gallbladder, into the gut. Next slide. Thank you. So for the purpose of this presentation, I will focus on two of the main jobs our liver does. One is the processing of bilirubin. So bilirubin actually is a byproduct of the breakdown of hemoglobin. Hemoglobin is the substance in our red cells that carries around oxygen in our bloodstream. When our body renews the red cell, breaks down the hemoglobin and forms unconjugated bilirubin. This unconjugated bilirubin is then in the liver cells conjugated, becomes conjugated bilirubin, and then this is excreted in our bile. So actually it's conjugated bilirubin when it's raised. That is the parameter of essentially sort of liver-related jaundice. If your bilirubin is generally raised, then it could be because it's just coming from breakdown of red cells and not necessarily be a problem with the liver. So it's conjugated bilirubin that differentiates between the two. On the diagram on the right, we can see here the blue surface is essentially the surfaces of two liver cells, and they're facing each other. And in the middle here, they would be excreting the bile. And you can see here where it says FIC1 or MDR3 or MRP2 and BSEP. There are these essentially membrane receptors, and what their job is essentially to they are very specific in connecting with various substances in the cells and excreting them and pumping them into the bile. So for example, BSEP would be a bile salt export pump, and it will attach bile salts and push them into bile, into the bile canaliculus. But this process is not set, it's not fixed. So these proteins, our cells will actually recycle. So they will use them up, they can increase them if more bile salt needs to be pumped into bile, or they can be reduced and so forth. It's very important that this process works well, because if there is an accumulation of bile salt in the liver cells, they are very toxic. They're just generally very toxic molecules, but more so obviously to the liver. These are the cells where they accumulate. Next. Here there's just on the left is just a very generic diagram of what a cell would look like. So in the middle here, the circle would be the nucleus where all the genetic material is, and then this would be translated into proteins that would be in the periphery doing their function. You can see that there is like a cell membrane, and up here on the right there's something that's called a vacuole. So essentially our cells have different ways of communicating with their surrounding cells, and one of the ways is to internalize a membrane there and like potentially like trap almost something into this vacuole. And what could happen is, for example, if you look further down, the vacuole infused with this lysosome here, which has lots of like toxic enzymes. And for example, if it was a little bacteria that was grabbed in the vacuole, that would be killed, for example. This process is also used when a cell is producing proteins and wants to excrete them to the environment. So again, it would pack the proteins in little vacuoles and then like bring them to the surface and release them to the surroundings. On the right here, you can see a hepatocyte that looks very similar to this. Again, the nucleus in the middle, and then the various organelles in the cells doing the work. But essentially, what's important to know about liver cells is that they have this sort of double interface. So they have a side of them that is connecting and communicating with small blood vessels, and then a side to them which is connecting and communicating with the bile canaliculus, where the bile is being formed and excreted. Next slide. Okay, so here on the left, we can see, again, it's a schematic diagram of a process called endocytosis. And you can see on the far left where essentially these receptors are being drawn into the cell when needed. and form these vacuoles, or otherwise really called endosomes. And our bodies are very efficient, and they will try and recycle these receptors back to the surface when they're not needed anymore. And there are other ways of doing this, a similar process here. And what this has to do with myotubular myopathy, if you look here on the right, this isn't a liver cell, but essentially you can see here there's an invagination formed here from the cell membrane. You have these early endosomes which mature to a late endosome, and then either are recycled back to the membrane or continue to fuse with the lysosome, and then their ingredients will be degraded. But myotubular, for example, plays a really big role in essentially activating and using some of the phospholipids on these membranes in the early endosomes and late endosomes as a substrate. And if you look closely as well, here at the top, Dynamine 2 also has a role actually in this process through, in fact, it influences something called clathrin-mediated endocytosis. Next slide. So endocytosis, of course, is very important for liver cells. This is a picture actually from like a hepatology textbook. And we can see here there's the liver membrane, the hepatocyte membrane, and you see the early endosomes, the late endosomes forming, and then to the right here, diffusion and the release of substances into bile. So if you look closely again, a lot of these phospholipids that are on the membranes of these endosomes are actually substrates of myotubulin. Thank you. So what we do know from patients unrelated to myotubular, X-linked myotubular myopathy, is that we have patients, for example, where these receptors, you can see here BACC, MYP2, for example, they are born with a genetic defect, and these proteins, for example, are just not being made. And these children will develop forms of chronic cholestasis and then chronic liver disease. But there are situations also where someone doesn't have manifestations from their liver usually, but then during an episode of sepsis, like a severe infection, where the cytokines produced as part of this inflammatory response to the infection have an effect on these receptors, and these receptors aren't brought to the surface of the canaliculi as they should do, and the patients would become jaundiced. And then also we have like drug-induced cholestasis, where a medication is directly toxic to these receptors. And again, we can have drug-induced cholestasis. And it's not unusual in these situations for the episodes of cholestasis to resolve when the infection gets better or when the effect of the drug diminishes. So one hypothesis as to how we get cholestasis in X-linked myotubular myopathy could be that this participation of myotubular in the process of endocytosis may be essentially affecting, maybe not all the time, but during times of maybe infections or certain medications being used, on how this transport of bile salts and other constituents of bile is happening from the hepatocyte to the bile canaliculus. Next one. Thank you. Moving on to liver peliosis. So liver peliosis or hepatic peliosis is extremely rare. There are about 15 patients that have been reported in the literature. Of course, there may be more that have not been reported. You can see here on the left, these are scans. The liver really should be looking like a light gray, but these dark circles on the scans are areas of blood. And what has been reported actually with liver peliosis is that some patients, particularly in Japan, were presented very unwell and shocked essentially because of this intra-abdominal bleeding, did survive with liver transplantation. They tried initially to embolize the vessels, but then had to proceed to liver-related transplantation for the children to survive. Next slide. In terms of the causes of liver peliosis, we don't really know what the mechanism underlying liver peliosis is. We do know that it's not something, in fact, X-linked myotubular myopathy is the only monogenic condition that's been associated with liver peliosis. We do see it, it's still extremely rare in other situations of essentially infections, sometimes infections in immunocompromised patients, and sometimes in patients taking medications. Next slide. I'll just look a tiny bit here about liver peliosis in the context of an infection with Bartonella, which causes cat scratch disease. Only because what we do know with this infection, for example, is that the Bartonella manages to enter the cells, particularly the endothelial cells, with the cells lining our vessels, and manages to stay in the endosomes almost of these cells, but is able to block the fusion with the lysosome. So actually, in that way, it avoids being destroyed. And then in addition to that, Bartonella also manages to trigger this increase of something called a vascular endothelial growth factor, and in that way promoting more vessels to be grown essentially, and in that way spread across the body. And that's just a picture on the right with essentially pictures of liver peliosis, but in the context of a Bartonella infection, which would actually get better with the infection being treated. Next picture. Thank you. So here again, on the left is Bartonella entering our system and then settling into the endothelial cells, which are these pink cells here in a row. And on the right is in the context of the liver. If you remember one of the initial pictures I was showing where there was a blood vessel in the middle and then the liver cells were lined up on either side. In reality, it's slightly more complex than that, and there's a very thin layer of endothelial cells protecting the liver cells. So the blood doesn't actually come into contact straight away with the liver cells, but there is a layer of endothelial cells, and it's probably the rupture of this barrier that causes the blood to fill the parenchyma, the liver parenchyma, causing these cysts. And it may be, even though the exact mechanism we don't understand, but it may be that, again, defective endocytosis in this endothelial cells, and maybe VEGF is implicated. Next slide. In terms of steatosis, again, the liver produces various lipoproteins, which it needs to excrete through vesicles again. It may be that this process is like slower or more defective. With steatosis, again, it sometimes also just need to also keep in mind that sometimes when we have patients or children being fed, for example, with gastrostomies, there may be also an element of overfeeding, and that can also result in some steatosis as well. Next slide. So this is just a list of various tests that you may be hearing about, and Regan will talk more about them. But essentially, in terms of blood tests for cholestasis, you want a high bilirubin, and it needs to be the conjugated bilirubin that is high. High bilirubin, but unconjugated, is not really indicating liver disease. Bile acids is slightly more specialized test, doesn't need to be done all the time, but it is a very good indicator of cholestasis. There are some more generic liver tests to do with the liver tests like the ALT, the AST, or the gamma GT and the alkaline phosphatase. They can be specific to the liver, but they won't necessarily always indicate severity of disease. More indirect tests looking into like how the liver is actually functioning would be things like doing the albumin and checking INR, essentially the clotting factors. And then in terms of imaging, I think Regan will talk again a bit more about this. There's a variety of ultrasounds, fiber scans, more detailed scans like MRI and CT. And then we'll be talking a little bit about biopsy as well later on. Thank you.
Thank you so much, Serena. That was really helpful and informational, and it's so wonderful to have your team at King's College and as a pediatric hepatologist helping our community. I'd like to next introduce Dr. Regan Foley from the NIH. She's a pediatric neuromuscular specialist, and she's going to speak about clinical care, how to follow liver issues in MTM and CNM. Thank you, Reagan.
Thank you, Erin. Just want to make sure, can you hear me? Yes, okay, great. So as Erin mentioned, I'm a pediatric neuromuscular specialist. I've had the privilege to take care of children and adults with myotubular and central nuclear myopathies, including, very importantly, female carriers of myotubular myopathy. And you're probably wondering why a neuromuscular specialist would speak about clinical care and surveillance of the liver. And that's because we often, along with the families, are the first ones to encounter liver issues. And so we can help with the surveillance. Next slide. And so these recommendations history, as Alan Begg spoke about, the natural history of the condition, meaning children not part of clinical trials, and how the liver may be involved in both myotubular myopathy as well as in central nuclear myopathies. We know in MTM, or myotubular myopathy, that liver involvement has really come into great focus more recently, given the findings we've seen in the gene therapy study. Liver involvement in other central nuclear myopathies is less well understood. However, it cannot be ruled out. And so I would recommend that a lot of these surveillance recommendations be carried over to all forms of central nuclear myopathy, because if you don't look, you won't find something. And these recommendations are really aimed to provide clarity on how to monitor for liver, or otherwise known as hepatic, involvement. Next slide. So just to kind of briefly recap, and you've heard from Serena in great detail, liver peliosis, or hepatic peliosis, is a rare liver condition, and it can be seen in myotubular myopathy, and it manifests with multiple blood-filled spaces in the hepatic tissue or parenchyma. And if unrecognized, it may lead to a fatal hemorrhage. And so what we do is we recommend performing liver imaging. We begin typically with liver ultrasound because it's non-invasive. It's just sound waves. Look at the image of the liver, and if there are any findings on the ultrasound, even subtle findings, we have a very low threshold to proceed towards liver MRI. And contrast can be very helpful with these imaging modalities to better really highlight any vascular abnormalities. So again, liver ultrasound, easy to do at bedside, does not need sedation. CT, you can go forward, has radiation, but can show you a very quick image in an emergency if there's evidence, and ideally CT with contrast, if there's evidence of these vascular filled spaces. But ideally, MRI would give you the best picture, the best image quality of peliosis. You can go forward. And so if we find any evidence of peliosis on imaging, then we recommend, obviously, the involvement of interventional radiologists to help us to treat this vascular abnormality. And angiography, along with hepatic artery embolization, can be considered and has been successful if peliosis is recognized. So the key is to recognize that the key is to be ahead of the curve and to perform sequential imaging, beginning with liver ultrasound. Next slide. So cholestasis, as Serena carefully and very well described, it's really a tendency of the slowing or stalling of the flow of bile. And it can manifest with what we call an increase in direct or the conjugated, what Serena mentioned, the conjugated bilirubin is the same as the direct bilirubin. And that's a key really terminology to recognize, because when you get liver function testing results, there's going to be multiple values. It is the direct or conjugated bilirubin, which is most important for us to look at. An increase in the direct bilirubin will also cause often an increase in the total bilirubin. But even if the total is not increased, but the direct is increased, that is an indicator for us of probably a tendency towards cholestasis. And cholestasis, especially if unrecognized, can progress towards what we call synthetic function, to affect the synthetic or the protein producing function of the liver. And because the liver produces clotting factors, which help with coagulation, coagulation can be affected. Next slide. So what we do is basically we have a really sequential plan for surveillance, for screening. What we do is we monitor for cholestasis by checking total and direct bilirubin, a simple blood test. And if you order what we call liver function tests or LFTs, that test includes total and direct, and often has the indirect bilirubin as well. But most importantly, the direct bilirubin is part of the liver function testing panel, as well as the ALT and the AST, the alanine transaminase to aspartase transaminases are liver enzymes. As Serena mentioned, they may be elevated in isolation, but the key metric or the key finding to look at, again, is that direct or conjugated bilirubin. Other findings you can see on the liver function panel would be alkaline phosphatase and GGT. These may also be biomarkers or signs that someone has a tendency towards cholestasis, but the most important metric is, again, is the bilirubin, in particular, the direct bilirubin. Next slide. So if we see there isn't the evidence of cholestasis, that increase in direct bilirubin, we can do things. That's why you want to check. And so we can start ursodeoxycholic acid, or ursodiol, which is really a naturally occurring bile acid. It's well tolerated, and often it's quite effective in normalizing cholestasis if, again, it's caught early. And we continue to monitor bilirubin very carefully, even while on ursodiol. And we also can consider monitoring serum bile acids. As Serena mentioned, they are also helpful. Not always been checked historically, but we're learning a lot. And so we think that checking serum bile acids really can be a potential kind of adjunctive or helpful biomarker or symptom or sign in the blood of cholestasis. Next slide. We have other tools for liver surveillance, and amongst liver specialists or hepatologists, there's been a lot of debate if transient elastography or so-called FibroScan can be helpful. And speaking to a lot of our colleagues here in the States about this, there seems to be a consensus that it can be helpful in the context of the clinical history and the examination, other liver function testing. If it's performed at your local hospital, it's helpful to have a baseline performed. What happened in the gene therapy study is we hadn't performed baseline FibroScan or elastography, but then started performing that during the clinical trial. So ideally, to get a baseline would be good to have a sense of the liver stiffness or fibrosis. And in general, the normal value or reference range should be a value of less than 7. So again, it can be considered an additional helpful tool in assessing the liver for the potential of cholestasis. We don't know the natural history of elastography values in children with central nuclear myopathies, and it may be at baseline elevated, but if we don't check, we don't know, and it's helpful to know what it is, especially before a therapeutic intervention. Again, it's not used in isolation, but along with other testing and examination, and it's been considered really as a tool for liver surveillance for clinical care, for natural history studies going forward, as well as for future clinical trials for MTM and central nuclear myopathies. Next slide. So if there is evidence of cholestasis, we have to always think, well, synthetic or protein producing capacity of the liver can be affected, including the clotting factors. And so we should always check. I'm going to say it again. We should always check coagulation studies. And the reason why I say that 3 times is, unfortunately, even in very specialized centers, the specialists don't think to look. We have to look at the coagulation. So we check usually a panel that has PT, prothrombin, PTT, INR. These are indices of how the body is forming clots and can form clots, and how the body is in terms of its ability to not have a hemorrhage. So you want to have normal coagulation values. You have to check. Vitamin K is produced by the liver, and vitamin K is really important for producing coagulation factors. If we see evidence of cholestasis, we can easily start vitamin K, and that can help support coagulation factor production. So again, we have to check. Next slide. In times of illness, the body's more vulnerable. And as Serena mentioned too, some things with the liver can become more exaggerated during times of illness. So cholestasis may actually occur for the first time during illness, such as with a fever or viral symptoms, or it may be already present cholestasis and become much more severe during times of illness. So we have to basically check liver function carefully and also check coagulation during times of illness. Next slide. Kind of as part of the spectrum of things to check during times of illness is that of platelets. And so most prominently in myotuberous myopathy, but also we think in other central nuclear myopathies, platelets can be affected, and they're often affected kind of intermittently. So platelets, when they're low, it's often called, we say, thrombocytopenia. And the clinical picture is often described as being similar to what's called idiopathic thrombocytopenia, which is an intermittent low platelets without a clear cause. in NPM1 and other central nuclear myopathies, there seems to be a correlation with fever and infection and the platelet count going down. We have to check, and we check that, you can go forward, by checking a complete blood count. A complete blood count has a platelet count part of it. So during times of fever and illness, push your local team or even local pediatrician, please check a blood count. Let's see what the platelet count is, because if the platelet count is low, we can do something about that. We can give steroids, and the platelet count often rebounds and normalizes. So again, always think about illness as being a risk factor for both the liver as well as the platelets. Next slide. So a lot of our patients and their families are very focused on being ready for the next clinical trial. And we want to make sure we also prepare all of our patients and their families for clinical trials. And the field as a whole has been done a really good job at studying natural history. Now we're focusing a lot on liver natural history. The field as a whole has done a good job at identifying outcome measures. Where we really need to focus now is to optimize clinical care, to make sure we're aware of everything going on and make sure our patients are really well looked after, and every element, including liver involvement, is taken care of. Next slide. So I include this little picture because one of my very dear patients with myotubulopathy loved cars, and he loved Lightning McQueen. We don't need to be super fast. We need to be aware there could be curves on the road. And knowledge helps to guide our surveillance and care. And this knowledge has been gained from absolutely invaluable lessons we have learned from individuals, particularly those with myopathy. And know that this knowledge is truly invaluable. Having this knowledge, you can navigate the road ahead. You can navigate any curve in the road and know that you have the support of the community behind you, not only other families, but also specialists who are also very eager to be a point of reference for you when you present to your local emergency room and no one has an idea about the implications of the liver in myotubular and central nuclear myopathies. Next slide. So I like to think of this as kind of providing all of you with a playbook for liver surveillance. So you can share this information with your local care team. And you can also seek out a hepatologist. So Serena, who spoke, is a hepatologist, a liver specialist, a gastroenterologist who also very specialized in the liver. And this is very important, especially if there's evidence of cholestasis, to seek out a liver specialist, a hepatologist. And this knowledge, as Erin pointed out at the beginning, is evolving internationally in real time, for which patient and family organizations, as well as the MTM and CNM patient registry, are absolutely essential for sharing this data in real time. And I want to kind of highlight that all of our efforts as international community of specialists, in the past, in the present, in the future, we really dedicate to the individuals with myotubular myopathy and central nuclear myopathy and their families around the globe, whose courage and grace are truly extraordinary and continue to inspire us beyond our imagination. And especially, you can go forward. I wanted to say, for all those who many of us have cared for, all those whose lives ended far too soon, we remain so devoted to ensuring your strong and lasting legacies. And so much of the data I just presented is really data that we've learned from children with myotubular myopathy and central nuclear myopathy who've taught us this information. And for their memories and their legacies, we must make sure we take note and help to make sure that we promote the best of care and the best of surveillance. Thank you.
Thank you very much, Reagan and Alan and Serena. We're going to pause here just for a quick minute to address a couple of questions. Reagan, I think we'll address the first one quickly to you. Questions coming in regarding, is testing for liver functions, particularly bilirubin and ultrasound, enough to rule out something that's more serious or urgent like peleosis? So if the liver function tests are coming normal, could there still be some bleeding or hemorrhaging that's not recognized?
Yeah, these are really million-dollar questions, very important questions. So we always do the liver function. We also look at the platelet count and coagulation factors as screening tests. So if the liver function is entirely normal from our perspective and the bilirubin, we will continue to do very careful surveillance, especially during times of illness. If the coagulation, the platelets and the coagulation factors, PT, PTT, INR are normal, we are less concerned at that time of the blood test of any bleeding. However, again, we should check again during illness because it can be an evolving picture. With the peleosis, we do the ultrasound as our surveillance. I'm going to defer to Serena on this because we have seen what we thought was normal ultrasound in patients that ultimately went on to develop peliosis, including hepatic hemorrhage. And so I think there should be a really low threshold in any abnormal ultrasound to proceed with further, more detailed imaging.
Another question, maybe for Serena and or Reagan, regarding, so ursodiol was mentioned as potentially effective in helping high bilirubin. Is that also effective, or in a case where elevated liver enzymes are noted persistently despite being on ursodiol with bilirubin normal?
So, if it's okay, I'll take that. So essentially, no. Ursodeoxycholic acid is a bile salt, so it just helps essentially make the bile a bit thinner and just helps it sort of be excreted. I do realize that quite a few patients with cholestasis are on ursodeoxycholic acid, and we use it a lot. We sometimes jokingly call it vitamin U. But when there is an issue with bile salt being exported into bile, just one needs to be a little bit aware when they're using it that it might actually make things a little bit worse. Because if you don't have your receptors there pumping everything out of the cell, it might be by giving more bile salt, even though like a nicer type, a kinder type to the cell, you might actually not be achieving what you are seeking, setting out to achieve. So by all means, it's a very safe drug. It can be used, and we use it a lot in children with like significant liver dysfunction. But just in terms of if you are a doctor using it, just sort of be aware that it may, particularly if it's a problem with bile receptors and things, that it might not help as much as you hope it will. And it shouldn't really, so someone that has more of a hepatic picture, like with high ALT, high AST, normal bilirubin, normal bile acids. I think the lady that put that there hasn't mentioned what bile salts might be. So sometimes you may have high bile salts with normal bilirubin. So there's evidence of subtle cholestasis, but it's not showing with a patient being jaundiced. But if bile salts are normal, bilirubin is normal, ursodeoxycholic acid, I wouldn't be anticipating making any particular difference to the transaminases, the ALT and the AST.
Great, thank you. There are other questions coming in, but I think what we're going to need to do now for the sake of time and make sure we get to all our other great content is we're going to move on, but we will try to either address questions towards the end of the webinar, or certainly we can follow up offline as well. So the questions are being noted and recorded in case anybody's concerned. So I think now we're going to move into part two. So after that great understanding of the background of some of the liver concerns that might just be naturally occurring within myotubular centronuclear myopathy, we'll talk a little bit more specifically about how things have are continuing to come to light in context of some clinical trials. So I'm going to hand off first to Dr. Michael Lawler from Diverge Translational Science Laboratory.
Okay, can you guys hear me okay?
Yes.
Okay. So thank you very much for the invitation to talk. I'm going to speak about primarily the ASPERO trial and some of what we've learned about liver disease as a result of the really unfortunate patient deaths in this trial. Oh, next slide, please. I have a couple of disclosure things. So in talking about a clinical trial, it's important to note that we're not actually trying to sell this agent, that we're trying to do data sharing, and that this is still an investigational compound that is under evaluation for its safety and its efficacy. So we are not trying to sell this gene therapy, but we are trying to share what information we can on it. Next slide, please. In terms of my personal disclosures, I'm a professor at the Medical College of Wisconsin, but I've spun out my research laboratory that has worked on these projects to a separate company called Diverge Translational Science Laboratory. I am the pathologist working on the ASPERO study. So that's the perspective I'm taking to the discussion today, where I'll talk about some of the pathological issues related to efficacy as well as safety in the study. Next slide, please. So it's going to be a 3-part talk, but the third part, frankly, is a slide because we're still working out the path forward. The idea here is really to focus on where the trial has gone and what we've learned during the course of it. The talks that have been given so far are really excellent in highlighting where the focus is now and what the background is. And so hopefully this will fill in some of the blanks in terms of why we were looking at things like hepatic ileosis as a worry at the beginning of the trial, and now why the focus is more on intrahepatic cholestasis as a significant issue in MTM. And on the way there, we'll talk a little bit about ASPRO itself. And so the ASPRO study itself is a AAV8 MTM1 gene therapy. The idea is to use a virus to restore or to add a full-length myotubularin gene to the cells and then to express myotubularin in the muscle and ideally replace what's missing. The inclusion criteria included males, most of whom were less than 5 years old and had genetically confirmed myotubular myopathy. They required ventilator support because that was the improvements in ventilation were an important endpoint. And then there was a liver-related inclusion criteria related to AST and ALT elevations and ultrasound findings. But it's really important to note that these were not necessarily made with cholestasis in mind. This was an attempt to avoid enrolling a patient that had a significant risk of hemorrhage from hepatic ileosis during the course of the trial, as it would have been difficult to distinguish a safety event related from the drug to the progression of hepatic ileosis to hemorrhage if that were to occur. So there were worries about the liver at the beginning, but they were much more related to hepatic ileosis. And frankly, as we'll talk about, cholestasis wasn't really on our radar as much because we weren't running into it that much as a significant issue in the patients, and we weren't seeing it at all in the animal models that we were studying the gene therapy with. In terms of the dosing, there's a low and a high dose, and then there's a control group of patients who were never treated, and I'll talk about the results there. And then the efficacy was assessed through a number of different neuromuscular, respiratory, and tissue-based endpoints. Next slide, please. So in relation to the respiratory endpoint, which is a really key endpoint related to safety here, a useful assessment is looking at how the ventilator use or ventilator dependence changed over time. And so you can see this graph has a gray, a blue, and a red line. The gray line is what the control or the untreated MTM patients over a period of 48 weeks. You can see that their percent change in baseline, so how much their ventilator usage changed, didn't really change very much in the course of this 48 weeks. In comparison, the patients with the low dose in the blue line, you have a pretty rapid and impressive decrease in ventilator usage following treatment, although not that many points were measured. And then the high dose, you can see that it improved at a slower rate with many more measurements being taken. And the thing here is that the key learning is that it's improving ventilator function, but the apparent difference between the two doses is the result of us adapting the trial as we learned more about it. So the early patients, there was an unexpectedly rapid degree of improvement in terms of ventilation. And so it wasn't until the later patients with the high dose that there was a really systematic approach to all patients to more slowly wean ventilator function. And that's kind of what you're seeing there. And a more frequent monitoring of it as it became a more important endpoint in the trial. Next slide, yep. So in terms of motor function, it's useful to look at the acquisition of motor milestones. You can see here on the right, the untreated patients which have the gray background. There's only a few of them that ever achieved the ability to sit without support for 30 seconds. In the treated patients, the low dose are in the purple background and the high dose are in the light red. You can see that many of the low dose patients are walking independently. A few of the high dose patients are walking independently, and most of them are at least sitting without support for 30 seconds. This is, promising in terms of the ability to restore motor function and is an indicator of motor efficacy in some patients, quite a bit of it. Next slide, please. Now, my role on the study is as a pathologist. So what a pathologist does is they take tissue samples, so in this case, a muscle biopsy, and we cut the tissue sample, we stain it, and we look for the patterns of what the cells look like, what cells are there, if there's any evidence of damage and things like that. And so first and foremost, to introduce you to what muscle looks like in myotubular myopathy, as Alan mentioned, you've got a couple of key abnormalities. Just look at the panels on the far right. The age-matched control is what the normal looks like. The baseline is what an untreated MTM patient looks like. And so you can see that the muscle fibers in the MTM patients are smaller. Some of the fibers have internal or central nuclei, whereas that's not a normal finding. And if you look at the NADH stain, where you are looking at mitochondria and other organelles that are supposed to be evenly scattered throughout each fiber, you see that in the myotubular myopathy patients, there are aggregations or clusters of mitochondria and other organelles within the cells. And so that's what we call organelle mislocalization. And so it's those three things, right? It's the small fibers, improper nuclear placement, and organelle mislocalization that are really characteristic of myotubular myopathy. And essentially all of the baseline biopsies for every Aspero patient looked just like the baseline biopsy that's shown here. When we look at the post-treatment biopsies, at week 24, you can see that the NADH stain doesn't show the clumping anymore, so the organelle mislocalization improved. The fiber size and the internal nucleation didn't particularly improve. And then by week 48, you can see that the fiber size has actually improved quite a bit, close to normal levels. And actually, the internal nucleation across patients still isn't necessarily improving very much. But but it's also debatable whether or not that's actually contributing to the weakness in any relevant way. So what you're actually seeing here is evidence that there is kind of a staged, very long-term recovery of muscle structure over the first year following gene therapy. And this provides some explanation for why you're seeing gradual reacquisition of motor milestones and ventilator improvements over that period of time. Now, this will be all I say about the efficacy. I'm now going to switch to talking about safety, and there are a variety of safety events that occurred in the trial, but I'm really going to focus on what was seen in the 4 patients who tragically died during the course of this trial. And so what you can see here is the liver histology from these 4 patients. And I'm just going to point out a few kind of commonalities. So in general, these patients had evidence of the same disease process occurring in the liver, and then it was just being caught at different times depending on when biopsies or autopsies happened to collect the tissue. And the key abnormalities included that there were hepatocytes, the cells, the primary cells of the liver. Many of them showed evidence of injury or the cells themselves had died. And some of the evidence of injury included accumulation of bile components. You can actually see that on the BSEP row as the green material, which isn't actually BSEP, it's bile components. And there's a lot of that stuck inside the cells, whereas Serena was saying the idea here is to produce those components in the cells and then secrete them as components of the bile. Other things are there's fibrous tissue in between individual cells. That's the light pink that you're seeing in between the cells. And then at the top panel, you can see that there is a different looking set of tubes in the top middle. That is evidence of bile duct proliferation, which is another indicator of bile duct injury. And then another element that you can see here is that there are some very big cells that have multiple nuclei here, particularly in the images for participant 12 and participant 40. Those are called giant cells. And so what you do as a pathologist is you take the set of abnormalities that you're looking at, and you say, okay, within this pattern and within this clinical context, what makes sense? And so if this was a patient that hadn't been treated and that did have cholestatic liver disease early in life for a genetic problem, this is really characteristic of a class of of diseases called PFIC, or progressive familial intrahepatic cholestasis. And that's related to mutations in a few key bile transport genes. And so our hepatic pathology specialist colleagues suggested testing for a couple of these proteins. And one of them was called BSEP, which is bile salt export protein. And what we found was that the BSEP expression, which is shown here on the right, and it should be a brown signal, which you can see isn't really there. BSEP was either absent, it was markedly decreased, or the condition of the tissue was so poor that they couldn't be interpreted. But it was, in no cases was it normal. And so this led to a suspicion that there was something wrong with BSEP to the extent that it wasn't allowing the export of bile protein or bile salts that were being produced in the hepatocytes, and that the accumulation of these things, which you can see in the cells here, was actually a component of the disease that was injuring the hepatocytes, and then a lot of these other changes were happening as a reaction to the hepatocyte injury. Next slide. And so how does this fit together with the patient's outcomes? So we have 3 patients that had a cause of death related to infection or sepsis, and we had 1 patient who had a cause of death related to hemorrhage. And as a few of the talks have hit upon so far, these actually track back to synthetic dysfunction in the liver, right? So that this common liver pathology, this common liver process across these patients can actually explain the different causes of death in these patients. And we're likely dealing with a single issue rather than multiple issues in multiple different patients. The idea here is that the liver failure is not producing adequate production of immune factors, which predispose to infection, or clotting factors, which predispose to hemorrhage. And what each patient experienced was a consequence of this common hepatocyte injury. There were also a number of other issues identified at autopsy that were attributable to issues in the liver, which are shown in the middle section here. And then there were a few issues that were noted that were not attributable to sepsis or liver injury. There were some things that were pre-existing and known at the time of trial enrollment. There were other issues, like one patient had evidence of a toxic exposure to muscle that didn't look like it was related to the gene therapy. It didn't look like myotubular myopathy, so it was likely related to something that was exposed during a prolonged clinical course in the ICU. So, there are things that you can put in the same bucket as the main disease, and then there are things that you can't, and this is typically how these autopsy investigations go. With respect to the muscle tissue, all patients had muscle tissue that looked very similar to what we would expect based on the other treated patients. So the impact, with the exception of the patient that had the muscle toxic influence, did look like the agent was doing what it was supposed to within the muscle itself. Next slide, please. So, this has really changed how we look at liver disease with myotubularin, and a few of the other talks related to this too. Up until this point, the patients were medically complex. There were, as Alan mentioned, there were a few studies that said that cholestasis happens in X-linked myotubular myopathy, historically, but it wasn't necessarily on the same level of visibility and importance as a number of other issues that these patients have. And it also wasn't recapitulated in the animal models. And so there wasn't really the opportunity to study it in the same way as the skeletal muscle disease and some of the other issues. Based on the situation that we've got here, though, it's clear that myotubularin has something to do with bile transport. And so there's a lot of work going on right now to kind of understand, first of all, the degree to which this is underappreciated in the patient population, and also how do we model it in animals? How do we model it in experimental systems so that we can recapitulate it and then see if we can prevent it or see if we can identify the risk factors associated with it. I can say that when all of this went down, I asked for and received all of the prior animal work related to myotubular myopathy and reviewed it myself in looking for any kind of evidence that we had missed in these animals, some evidence of cholestatic disease. And it's simply not there. The animals that were treated coming up to this trial didn't have any kind of cholestatic disease, and it did not appear after treatment. And there were studies done in non-human primates that went to far higher doses. These primates did not have myotubular myopathy, but they did receive very high doses of AT132, and they also didn't show any evidence of liver disease. And so this really does appear to be a combination of a background of myotubularin deficiency and an exposure to AT132 as two of at least three risk factors associated with this fatal outcome. Next slide, please. Now, looking back at the information we've got, so the Inceptus Natural History Study, there were a significant number of patients that had a history of hepatic disease, a large number of patients with abnormal liver function tests, large number of patients with adverse hepatic events, and one of these patients died of hemorrhage-related hepatic peleosis. And so as we look closer and harder and use different criteria for the presence of liver disease, you can see that this is an issue that is, that some element of liver disease is common in myotubular myopathy. But again, distinguishing what's due to hepatic peleosis versus cholestasis, those are two very, very different things. And the things that you do to evaluate for peleosis are not sensitive to evaluating for cholestasis in most cases. Next slide. And so as we put all these things together, we also were looking at the MTM community in terms of, okay, who has particularly severe cholestasis? Where do we have liver, material that we can look at for evidence and everything? And so we had in the congenital muscle disease tissue repository, we had 6 liver samples from autopsies of untreated patients that had died and donated their liver tissue. And what we found was that there really wasn't anything in there that looked like what we were observing in the trial to the extent that we were observing it. And so 4 of the patient livers were completely normal histologically. That's what you can see on the left. Then there was 1 patient liver that had very mild evidence of cholestasis. You can see a little, it's the one on the right. You can see a little bit of green signal in some of the the ducts, but you don't really see much bile accumulation within the hepatocytes themselves. You don't see any evidence of injury, any giant cells or anything like that. So this looks very mild and potentially reversible in nature in terms of the cholestasis. And then the other thing that we had a chance to do was to look for BSEP expression, because it was unclear whether or not the absent BSEP in the treated patients was just a consequence of myotubularin deficiency or if it was related to treatment. And what we saw is that we were able to see BSEP. You can see the little brown lines in both of these cases on the surface, on one of the surfaces of the cells. That's what the BSEP signal is supposed to look like. And so myotubular myopathy doesn't cause problems with BSEP, and a deficiency of BSEP may not be related to what the cholestasis in untreated patients is. And and then conversely, we seem to have low BSEP or absent BSEP when you have in terms of the treated patients. And so it's possible that there is one component that disposes to cholestasis, that is the absence of myotubularin, and then potentially a loss of BSEP that may be related to AT132 exposure that then increases the likelihood of progressive severe cholestasis at that point. One other thing to note, though, is that there are a number of patients in the study that didn't have these cholestatic outcomes. So, there is a difference between the patients that have cholestasis and progress to liver failure after treatment and the ones that did not progress to liver failure after treatment or did not have any kind of cholestatic response. And at the moment, we do not know the difference between these two populations of patients. There's got to be a third risk factor that we don't completely understand or haven't identified yet. Next slide, please. So in summary, while these 4 participants had different reported causes of death, it's the cholestatic liver failure that's the real problem here that contributed to it in all 4 of these patients, and it looks fairly similar across 4 patients. The cholestatic liver failure seems to be related to a previously underappreciated, at least, cholestatic tendency in MTM patients and the exposure to AT132. There is evidence that BSEP is decreased in expression, and that may provide a mechanism around that. And then there is an additional factor that we haven't been able to identify yet that will hopefully explain the difference between a patient having a liver failure following treatment versus patients that do not have any kind of liver response. And we're still working very hard on that. As mentioned in the prior talks, the ASPRO study is still on hold while we continue these investigations. Next slide, please. And so just in closing, the plan for ASPRO and MTM gene therapy in general is really continuing to evolve. So on the scientific side, we're trying to work with investigators around the world, many of whom are on this call, to identify and develop appropriate experimental systems to study this and to better understand the risk factors involved with cholestatic responses to gene therapy and MTM. There's also a need to think about how the trial is designed, discuss that with regulatory experts and address the clinical hold scenario. The idea behind that, of course, is to get things moving again in as safe a way as possible while recognizing the urgent patient need for a treatment in this disease. And in doing all of this, it's critically important to engage with the patient community and experts in each of these areas. And hopefully the participation in this webinar is a good early step towards doing that. Next slide, please. And so we'll take questions in the Q&A at the end. I will just say as a primer, so I'll be there, and Dr. Marcus Marialainen from Astellas will be there. There is some limitations in what we can answer today versus what we can answer later versus what we can answer at all. Some of this is related to things that we're still trying to figure out, and some of it is related to limitations on what can be answered in a active clinical trial that is still under investigation, but we'll do our best to do that. Next slide. And I thank you all very much for your attention, and please know that we are working on this. Thank you.
Thank you very much, Dr. Lawler. And we also want to thank Dr. Marcus Marialainen for helping to prepare this talk for our community and for Astellas Gene Therapies for participating in our collaborative and helping to bring this information to the community and coming together to really try to problem solve the liver issues. Next, we're going to hear specifically from Nicole Verman, and just to give you a little bit of background of how what Nicole is going to be presenting on is our patient community has been also familiar with Dynacure that was working on the Unite CNM trial. Shortly ago, several months ago, we received information from the patient community that the trial was going to be ending, and there were a lot of efforts through our work and many others to make sure that the information that has been gathered in that trial was stewarded in a way that can continue to be ongoing and used and benefit from that knowledge. So I want to just call out also Belinda Cowling for assisting our Liver Collaborative in championing, trying to pass on and make sure that that data and that information lives on, and for Nicole for partnering in that effort, and that's what she'll be speaking about today. And Nicole is a neurologist from the Netherlands.
Thank you, Erin. And first of all, I would also like to ask Sophie Colombo to start her camera, because this is what I'm presenting on behalf of both of us, but there was a bit of discussion before today what could be presented and what not. So unfortunately, she's not as a photograph on this image, but Sophie, maybe you can say hi.
Yes, hello everyone. So I was working at Dynacure, and so just to inform everyone, as of February 15th, Dynacure merged with another startup company called Flamingo Therapeutics. So I work with them now, but working with Nicole very hard, and also the help of Mike, Anil, and others in the communities to try to publish some information we collected on the patients that were in UNITE-CNM clinical trial.
Thank you, and I think we're a good team. I'm the clinician, Sophie's the scientist, and we learn a lot of each other, and we've been working hard on this. And because most of you probably don't know me, I just thought to put in a slide of the hospital where I'm working, and I'm working there today, even because I'm on call, so I hope not to receive a phone call in the next 10 minutes. Next slide, please. I'm working in one of the university medical centers in Nijmegen, in the Netherlands, called Nijmegen. We have a wide team of experts focusing on patients with various neuromuscular disorders, including rehabilitation specialists and neurologists for adults and for children. And we are the national expertise for congenital myopathies, and that's why I'm involved in this field. Next slide. We will give a short introduction about the UNITE-CNM trial and about the methods, but I think that can be skipped because it has been introduced nicely in the first part of this meeting. And then we share some of the results. And I have not put a disclaimer in this presentation, but in fact, we have the same disclaimer as Mike had, in a way that this is research which is ongoing. So we will be working on the interpretation of data in the next weeks and aim to submit it to a medical journal as a manuscript later this year. But we've been working hard to get all the data together, and this is the first time we're presenting this. It's not a final project. So the next slide, please. The background of the UNITE-CNM trial. Yes, well, it's just starting to talk. This is just a title slide, so you can go to the next one. The background of the drug or the compound tested in the UNITE-CNM trial is the idea that in both X-linked MTM and the autosomal dominant central nuclear myopathy due to dynamin-2 mutations is in an excess of dynamin-2 protein in muscle cells. So mutations either in the gene MTM1 or BIN1 or in dynamin-2 all result in an excess of the protein dynamin-2, and that has an important effect in muscle function. So the concept is that when reducing dynamin-2, you can treat different genetic causes of central nuclear myopathy at once. So in this trial, two kinds of central nuclear myopathy were included, both X-linked MTM and central nuclear myopathy due to mutations in dynamin-2. Next slide, please. The drug which was being tested is an antisense oligonucleotide, which is a synthetic drug aiming to reduce the amount of RNA. So there's a defect in one of the genes, which leads to an excess amount of RNA of dynamin-2. And when you reduce it with an antisense oligonucleotide, the idea was to treat the muscle phenotype, so the muscle defect. And that could be used for the different types of central nuclear myopathy, as I mentioned. And this has, of course, first been tested in animals, in mice, the results of which have been presented by Belinda, I'm sure, before in one of these meetings. And then the UNITE-CNM trial was the way to bring the results of the preclinical studies in animals to patients who are a member of this patient organization, of both patient organizations, but also the patients in Europe, which are partly member of Zusammen Stark. And it was aimed to, it started to test the antisense oligonucleotide in patients above the age of 16 years with either genetic cause of central nuclear myopathy. Next slide, please. This is a summary of the design of the trial. It was a combined phase 1/2 trial to assess the safety, tolerability, and first signs of efficacy, so of effect of this drug. And it was divided in 3 cohorts, low dose, middle dose, and high dose. And all patients started with a single dose of the drug. So first a single dose in the low dose, then the single dose in the middle dose, and then the multiple dosing, the MAD phase in the low dose. And that is what you can see here. So one dose, a washout period, a lot of safety assessments, and then the low dose, the single dose in the middle dose of the drug, etc., etc. And that is a way of testing a drug for the first time in patients where you don't have data of healthy controls, which were exposed to the same drug. And it's a complex design, but it's a way to make sure that the patients are, to try to make sure that all patients who are in the trial are safe. Can we go to the next slide? This slide shows what has been able to be performed. So 6 patients were in the SAT1 cohort, which is single dose in the lowest drug dose, and then 6 patients were dosed in the middle dose, also once. And after that, the trial continued with the multiple dosing, so the weekly dosing of the low dose of the drug. And during that part of the trial, side effects were remarked, and eventually it was decided to stop the trial. What we will be able to present today is the findings at the beginning of the trial. So all the assessments which were performed on liver function at the onset of the trial. We are not able to talk about anything which was measured or assessed in the course of the trial. So the next slide. Which data were collected? So that is in line which was presented in one of the presentations before. There was blood collected during the screening, so at the onset of the trial, to assess liver function. These are the liver function measurements which have been mentioned before. And there was also imaging performed. At first only an ultrasound, but later also this FibroScan, which was mentioned by Regan. Can we have the next slide, please? Okay, next slide. Well, these aspects have already been explained by Regan. There are different measures of liver function in the blood, which are applied in daily practice very often. General measures of liver cell damage, which are ALT, AST, and LDH, and general measures of bile duct damage, which are gamma GT, bilirubin, direct and total, and the total bile acids. The next slide shows what you can see with ultrasound. On the right image, you see an ultrasound being performed of the liver and the kidney, what you can see there. On the left images, you see examples of a normal liver, a fatty liver, this cirrhotic liver, so when there's fibrosis, which is a final pathway of liver damage, and this paleosis, which was also presented. And with a muscle ultrasound, you get a general image of the muscle, as you can see here. And this FibroScan is a specific method of ultrasound to assess the stiffness of the liver. And this is a sign of damage of the liver in general, and is expressed in digits which are called F0 to 1, which is mild, F2, which is moderate, F3 severe, and F4, a score of F4 on the FibroScan refers to a cirrhotic liver. Okay, the next slide, please. And then what has been done as well, and maybe Sophie, you would like to present this method because that's your piece of cake?
Sure. We were interested to understand the expression of Dynamin 2 in the liver. This has, it's never performed before. So a lot of studies, for example, in animal models were done on muscle, or also in the liver, but in humans, we didn't really know what was the expression of Dynamin 2 in the liver. And even in muscle, there's little information. We were lucky enough to be able to get healthy and XLMTM livers. We'll present the data in the next slide, but it's just to present the method. So it's called the Western blot. So basically you will lyse your liver tissue And so you will have a mixture of all the proteins in your tissue, and you will run them on a gel with electrodes. And so it's going to separate the proteins by their molecular weight. And then you use antibodies that are directed against your specific protein of interest. So in our case, Dynamin-2. And with a chemiluminescent staining, then you can visualize on a membrane the protein Dynamin-2. So that's what you see in the panel D. Yeah, and I will present the results.
Yes, so in total, 26 patients were screened, 14 of them which were enrolled in the trial, and 12 were considered to be screen failure because they did not meet the enrollment criteria. And you can see here that it was a nice mixture of patients with Dynamin-2 mutation, so autosomal dominant central nuclear myopathy, and patients with MTM, so X-linked myotubular myopathy. Here we see the data of the 14 patients which were enrolled in the trial, showing the pre-existing liver history in one of the middle columns, and then the findings of ultrasound, of FibroScan, and the blood test. And you find that of the 14 patients enrolled, some of them had more moderate or mild liver steatosis preceding the trial. And in some of them, that was considered to be a symptom of the increased body mass index, so of increased body weight. And so in some of them, it was related to this disorder, which was also mentioned before, a common genetic disorder called Gilbert syndrome, leading to increased values of some of the liver function tests. The ultrasound also, can we go back? Also showed steatosis in 2 of the patients, and then we had an abnormal FibroScan at screening in 3 subjects. The liver function tests are also shown in the right column, and they showed mildly elevated bilirubin in the 2 patients with Gilbert syndrome, and that was diagnosed during the trial. Both patients were not aware that they had this genetic disorder. Okay, the next slide. And then this shows the data for the 12 patients who were not able to participate. And there we saw 5 patients with mild steatosis or moderate steatosis on the ultrasound, and also elevated F-scores at the FibroScan. And here we found that some patients with elevated ALT, gamma GT, or bilirubin. Okay, can we have the next slide? And this is when I hand over to Sophie again.
All right, so those are the results of the analysis of Dynamin-2 protein expression in the liver. So we had obtained 5 healthy adult livers, 6 healthy pediatric livers, and 4 pediatric livers from deceased XL-MTM patients. And those were provided thanks to the congenital muscle disease tissue repository from Mike Lawlor. So I want to thank him and the patients the families who contributed to this repository, because it's very useful, obviously, to have tissue from the patients to try to understand better the disease. So what we observed first in the healthy individuals is that in the liver, you have a decreased Dynamin-2 expression over time with the age. So you see that in the pediatric patients, there were higher levels than in the older patients. And actually, that's something that's not shown here, but we did the same thing in healthy muscle, and we saw exactly the same thing. There is a decreased Dynamin-2 expression in muscle in the normal population, and that's something that has also been recently published by the team of Mark Bethune. But we didn't know in CNM patients if there are changes in Dynamin-2 protein expression in the liver. And we compared the expression of Dynamin-2 in those 4 XL-MTM pediatric patients. And so those are the orange dots you see on the graph on the right. And you can see that if you compare to the healthy pediatric patients that are the blue, the levels are lower. They're more similar to the levels in the adult healthy population. So unfortunately, we did not have adult XLMTM patients or patients with the autosomal dominant CNM, so the form with Dynamin 2 mutations. And it would be very interesting to analyze also the protein levels in this population, because it's possible that in the CNM population, Dynamin 2 levels in the liver are quite low at baseline. So you don't want to reduce more Dynamin 2 in the liver. Because in the muscle, as Nicole mentioned in the introduction, the common mechanism of central nuclear myopathy is an increased Dynamin 2. So in the muscle, there's increased Dynamin 2. So it makes sense to want to reduce it. But if in the liver, it's already low, probably you don't want to reduce it more. But we need obviously more samples. We will need to analyze more patients, different ages, different types of CNM to really confirm that's a commonality. And also we need obviously to understand better Dynamin 2 function in the liver. We do not know its function in the liver. So that's definitely further investigations that would be very essential.
Thank you. Next slide. And going to the conclusion on the next slide. Well, the main summary is that we found minimal hepatic involvement in most patients, not only in X-linked MTM, but also in autosomal dominant central nuclear myopathy. And 2 patients were not aware that they had Gilbert syndrome. A minority of the patients had evidence of liver injury on the liver function test. And 7 out of 26 had evidence of steatosis on liver imaging at screening, partly related to the high body weight. There was no evidence of hepatic biliosis on liver imaging in any of the X-linked MTM patients in our trial. And there were no signs of cholestasis at baseline. Dynamin 2 protein levels may be lower in the CNM population, as Sophie pointed out, but that needs to be investigated further, as she mentioned before. And then the next slide, please. I think what I would really like to address is that the UNITE CNM trial took place in parallel to the Audentes Astellas trial, and the protocol of the UNITE CNM trial was amended several times to add additional liver function tests, to add the ultrasound also for autosomal dominant central nuclear myopathy, and later to add the FibroScan, because what was observed in the other trial. And this made sure that in spite of the side effects, all subjects were healthy after the stop of the trial. And it was a very intense trial due to that, because of all the changes for the patients and the study teams. But I'm very relieved that it took place and that all the patients recovered after the stop of the trial. And that's all we would like to share today, and we will continue working on the interpretation of data and are looking forward to be able to share it in more detail at a later point. And I would like to thank the patient organizations for organizing this webinar today. Thank you.
Thank you so much, Nicole and Sophia. This was exceptional. I do want to just call attention that I just want to appreciate all of the efforts you did to help bring this data and information to the patient community, and just to recognize for everyone on the call that the collaborations between patient organizations and industry is essential in moving this forward, and really encouraging the transparency of data, which all the professionals involved today are very committed to. And so I just want to bring attention to, we didn't have some promo around your talk because, you know, certain sign-offs had to happen in a timely way, and I just appreciate all the advocacy that we were able to deliver what we were able to in the last session. Moving on, we recognize that we are running behind, but we really appreciate everyone being here, and we have really quality information to share, so we're asking for your patience, and we'll continue forward and hopefully be able to address some questions at the end. Our next panel is on how do we handle this as a community? How do we all come together? And I'm going to kick this off by just talking a little bit about the Liver Collaborative Working Group. Next slide. And this really grew out of an organic process. Next slide, Mark. So some of you know my son, Will Ward, who lived for 20 years with MTM. And really, liver issues were not a huge part of his treatment through the years. He was very healthy in a lot of ways. And we did have some elevation of liver enzymes, but it was really in his last few years of his life where these issues started to crop up. He experienced in this last year of life both a cholestatic episode, but it was treated with Ursodiol. And then also he had a potentially catastrophic ileosis episode, but he also recovered from that. So I think that's an important story to share. And Mark and I and our team and all the people you see here are really committed to gathering the information that we've learned and sharing it with others. This started very much in an organic way in those last year and a half of his life, where we were working closely with our Boston Children's team, Dr. Alan Baggs, Dr. Robert Graham, and also pulling in specialists like Mike Lawler to have conversations about how to address these issues for Will. And then also through that knowledge of what we've learned and how to address some of these issues, we started sharing with any patients where we saw within the community on social media, and also linking with Anne Lennox when she'd flagged some issues with patients over in the UK having issues. And it was through that collaboration that Anne introduced us to this amazing team from King's College, including Dr. Heinz Jungluth, who is the pediatric neurologist that's been involved with our community for many years, linking us with the pediatric hepatologist specialist, and Dr. Professor Anil Dewan and Serena, who you met today. And all together, we started organically meeting and talking about what we could be doing to focus on this issue and assisting individuals in the greater community. So from there, we went on to pull in slowly over time different people that were trying to encourage to share data, to better understand from what other people's small individual efforts were doing and come together. Next slide. So over the course of the year and a half, we've had multiple conversations with these individuals, and this is not an exhaustive list in terms of we want to keep growing this initiative. If you have an interest in this area, you're working on efforts, please join us. And it's only through coming together that we can really make the changes that we hope to do. So we meet on a monthly basis, and we try to take actionable steps towards accelerating knowledge in the community. And next slide. Our goals are really to form that stakeholder group. And right now, currently, our focus is on the mechanisms of myotubular and other related proteins and how it's related to liver. We promote collaborative efforts, and our focus is a dual focus, both on the care for today as well as mitigating any risks for potential therapies. And then also a focus on collective data sharing. And you'll be hearing that shortly in just a moment. But it was very intentional for us to think about, as a group, what would be the fastest way to start collecting data. And we really thought that patient-facing collection data would be something that we could arm all of you with the ability to join us in this process, and to think about ways that you can better follow and track your liver data for your child or yourself as a patient, and to pool that all together. So we developed over the course of the last several months a liver questionnaire that's going to be facilitated through the Myotubular and Central Nuclear Myopathy Patient Registry. Next slide. And our accomplishment to date is that we've been able to successfully meet on a monthly basis. We are accelerating investigation in a collective way. We've developed this liver webinar, but also the registry questions. So I'm going to quickly turn it over to Anne. She can share more about the patient registry.
Thanks, Erin. Can you hear me? Great. So we also thought it would be helpful for you to, before we just go into an explanation of the liver questions that you can add to the patient registry, just to tell you a little bit about the registry. And the principal behind it. I could just go back a tiny bit to just say, for anyone here who doesn't know what a patient registry is, sorry, Mark, I meant the slide is going back a bit, thank you. Basically, a patient registry is a research database. It holds information on who you are, what your age is, where you live, what your genetic mutation is, what the clinical information about you, how your condition affects you. And the great thing about registries is that they pool together groups of patients who fit a particular category. For us, the category, of course, is myotubular and central nuclear myopathy. But what it means is that people can quickly find participants for trials, gather data historically, but gather data going forward in the future should somebody start taking a drug or be part of a treatment, that if they continue to be part of a registry over years, you can continue to even gather information after treatment. And basically creating a link between the research community and patients, and in a way that empowers patients to decide what they can provide. That's the kind of principle of what a patient registry is. Next slide, Mark. But taking the principle that we all in this community obviously believe very strongly about, of not about me without me, this registry actually began deeply embedded in the patient community, and it started way back in 2009. And I have to name Wendy, the co-founder of the Myotubular Trust here, because this was her passion. She literally saw the light, and she could just see it in the distance that this was something we needed to do as a community. We were at a neuromuscular conference where people were discussing the barriers to translating research for our community. And which should have been obvious to us, one of the barriers was, how would researchers know that they could find enough of us? And how would companies decide it was even worth starting down the avenue of looking at our condition? And in fact, this conversation was being had about Duchenne and spinal muscular atrophy, and people were worrying about it. And we came away in slight shock and horror that if that's a problem in these communities, what would it be for our much rarer condition? So why we set it up in the first place was so we could be found, and so that they would know that not only could patients be found, but data could be found. And over the years, I've met people, who are hard-nosed venture capitalists for whom they won't put money into companies that might come into our field unless they know you can find us are very rare, and not just a rare population, but a population where we work very hard to get through our days, and we may not have time to be found. What was really important, we realized, was that the registry would be specific to our disease, that we wouldn't be some tiny percentage of some more generic general registry, because in order to be convincing, to researchers, to companies coming forward, if the registry has only our disease, then it's very clear 100% of the people on this registry are our disease. Ideally, that they have their genetic mutation to hand, and that be properly professionally curated, and that it be independent of us as patient organizations. So although we did develop it finally launched it in 2013, we ran it until it was operational and populated, and then with massive relief handed it over to Newcastle University, because it's really important that data like this lasts a long time, that it goes way beyond the temporary people we are in our organizations, and that that the people who want to use the data and know that it has longevity, know that it won't disappear if we disappear. And also that people who take time out of their challenging lives know that this data is not going to disappear down a hole. It will be available, and that is achieved by making sure it's in an academically rigorous place such as a university. And also, although we started the registry, we knew that at that time we were deeply embedded in best practice around registries and registry questionnaires, but we wouldn't be able to keep that up. And so by being in a proper home for registries, that it would always be at the leading edge of registry best practice. Next slide, Mark. So some of these I've already said in what I've said so far, but a good best practice leading edge registry for a rare disease, in our view, very much needs to be disease specific, so that if it's unequivocal, we can be found, and we're contributing to something that's about our very rare disease. It needs to be global, because we're too rare for this not to be a global initiative. You need a strong steering group when you run a registry, and this registry has a very strong international global steering group, highly represented amongst the patient community, but also from leading researchers in our field around the world. That it exists within an organization that can get ethical approval in its locality, as Newcastle has done, so that anything that we do is overseen by ethics, and that it is rigorous and objective. I hope I haven't raced through that so fast, but if anybody wants to follow up with any questions about the registry, where it came from, do send me an email. But Jo is now going to tell us about the questionnaire for the liver that has now been added to the registry.
Thank you, and hello everyone. Well, I'd first like to thank Erin and Anne and the rest of the Liver Collaborative Group for inviting the registry to collaborate in this important work. And I'm just going to spend the next 10 minutes talking to you a bit about the registry and about the liver questionnaire that's been developed by the group and how you can contribute to this research. Next slide. Sorry, next slide, Mark, thank you. So as Anne mentioned, this registry is a disease-specific research database. It's managed by the John Walton Muscular Dystrophy Research Centre at Newcastle University in the UK. We accept registrations of living or deceased individuals diagnosed with MTM or CNM and female carriers of X-linked MTM from any country, and as of this week we have 450 participants. Registration is voluntary. Adult patients can register themselves, and patients under the age of 16 must be registered by a parent or a legal guardian. The whole process, including consent and providing the data, is done online. This includes the upload of genetic or muscle biopsy reports, which we need to see in order to validate the registrations. You can nominate your doctor to provide some clinical data to your record if you wish, and we will also ask you to update your questionnaire responses every 6 months. We hold ethical approval from our local NHS Research Ethics Committee. We're governed by an independent steering committee, which is co-chaired by Jim Dowling and Anna Bouge-Bello. And we have as our academic and clinical lead, Dr. Chiara Marini-Bertolo as principal investigator at Newcastle. So on the right of the slide here, you can see the main areas of data that we collect, with 2 new areas highlighted. The liver questionnaire, I'll tell you more about in these slides, but we are also partnering with the Hospital for Sick Children in Toronto to provide recruitment support and data collection for a brain MRI study in X-linked MTM. Now, this isn't live yet, it will be opening soon. And Jim was going to tell you a bit more about this after me, but I'm not sure he's been able to join. So I can explain in brief that not enough is currently known about how MTM and CNM affect the brain and central nervous system. So this study will investigate whether people with X-linked MTM and their family members have any brain or neurological conditions that are detectable by brain MRI. The study will be open to any individual with genetically confirmed X-linked MTM who has had brain MRI imaging done. A few data points will be collected from the patient or family, but most data will need to be provided by the treating physician. So if you are interested in taking part, please contact me and I will give you more information to discuss with your doctor. Next slide, thank you. The registry works by collecting data from affected individuals and also from their doctor in some areas where we have consent to do so. The data are cleaned and looked after in a central database, which is managed by me and the registry team and made available in a de-identified form to support research and therapy development. On the left here, you can see an overview of what's involved when you join. So you start by creating a login and selecting your type of registration. It is possible to add multiple patients to one account. So this is useful, for example, for a female carrier who wants to register herself, as well as an affected child or children. Consent information is presented directly after registration, and once consent is completed, the questionnaire is unlocked. You have the option of nominating your doctor to provide some clinical data, and we ask you to upload a copy of your genetic report if you have it. The questionnaire has a number of sections, and from your data overview page when you log in, you'll be alerted to any incomplete sections. And like I say, you'll be prompted every 6 months to update the information. Now, the majority of our communication is done via email, so please, if you're taking part in the registry, make sure you type your email address in correctly and let us know if you change it. Next slide, please. The registry questionnaire and other registry documents are available in 10 different languages. And to date, we have 55 countries represented, with the largest cohorts currently being the US, UK, and Germany. Next slide, please. So now I'll just walk you through the new liver section, which has been developed by the Liver Collaborative Group, and which was added to the registry at the start of April. So it's available now to complete. Anne and Erin are having this new section translated into all 10 registry languages with the help of our fantastically supportive community. But in the interim, the new questions will appear in English, regardless of which language you've selected. We will announce the translations as they're released, but if you are a native speaker of one of the registry languages and you think you can help, please get in contact with us. So on the slides now, you'll see screenshots of the full questionnaire, but I'm also just going to briefly talk through the items that we've included. So you can see we're talking about diagnosed liver conditions, issues with high bilirubin or jaundice as a newborn, liver-related symptoms, lab test results, and liver-related hospitalizations, of which you can add multiple. Next slide, please. Frequency of liver-related blood tests, different types of liver imaging scans performed with their respective dates, and any abnormal findings from those. Next slide, please. We also ask about who reviews the liver health of the patient and how often this is done, about medication taken for liver issues, which you can also add multiple, and about history of liver biopsy. Next slide. Finally, we ask a global impression question about how liver issues are currently affecting the general health of the patient. And there is also the opportunity to provide any additional information which you think might be important but has not been captured through those questions. And these liver questions and the data that comes into the registry through them is now part of the main registry questionnaire. So the data will be managed and made available to the community in the same way as any other registry data. And next, I'm just going to quickly describe how that works. Next slide, please. So when we receive a new registration, the first thing we do is check it to make sure that there's nothing missing and that there are no obvious inconsistencies. So we may come back to you with questions. If you choose to nominate a doctor, then they'll receive an automatic notification and a request to log in and provide some data to your record. If you want to use this feature, but your doctor doesn't appear on the list in the registry, contact us and we'll invite them to join. And if they accept the invitation, then their name will appear on the list for you to select next time you log in. If you've had a genetic test, but you've not uploaded a copy of your genetic report, we will follow up for this as well. It's really important because it's the easiest way for us to validate the registrations. And we also can extract genetic information from that to hold against your the rest of the information that you provide. If you don't have a copy of your report, please ask your doctor for a copy and then log back in and upload it. We can request this from your doctor if you need us to, but it's often easier for them to provide you with a copy due to data protection regulations. You can log back into the registry at any time to view or update the data that we hold about you, but we will prompt you 6 monthly to update it, and your doctor too if your registration is linked with one. And of course, you can ask for your data to be removed at any time. Next slide, please. So now that we have your data, how is it used? Externally, from the registry team at the university, any group or company or even individual can submit a registry inquiry, of which there are two main types. So for data inquiries, we provide an aggregated data report or a file of de-identified patient-level data. And this is usually to answer a specific research question or to support feasibility planning for clinical trials or epidemiology studies. And for recruitment inquiries, we send information about clinical trials or other research studies to registry participants who appear to be eligible based on the information that we hold about them in the registry. Internally, we use the data in the registry to write papers, produce posters, or to contribute to presentations such as this one. All inquiries, regardless of what type of inquiry they are or where they come from, must be reviewed and voted on by our independent steering committee, and at least 2/3 of the committee must vote in favour for the inquiry to proceed. If you're interested, there is more information about how we store and use data in the legal notice, privacy notice, and data protection statement on our website. Next slide, please. This is just a quick glimpse at our fantastic steering committee. You can also read more information about each member on our website. Next slide, please. So what next? So to take part in this research in the registry and specifically to complete the liver questionnaire, you first need to have joined the registry. If you've already joined, you can just log in and you'll see the new section of the questionnaire from your data overview page. It's called liver function. If you need any help or if you're not sure whether you've joined already, please check with me first before just creating another registration. My email address is on the next slide, or you can find it on the registry website. And finally, please spread the word about the liver questionnaire and the registry as far and wide as you can so that we can collect as much information about this as possible. Next slide. We do have a Q&A session at the end of the webinar today, but if you have any questions which aren't covered during that, please feel free to contact me if it's about the registry, or Erin or Anne if it's about the work of the Liver Collaborative Group. Thank you for your attention.
Thank you so much, both Anne, for the information about the registry, and Joe, thank you so much for being great stewards for the patient information. And we're excited for the launch of the liver questionnaire and really invite you all to be active participants. We're really only going to understand these liver issues if we can pull together and be willing to share data, and inviting you into being an active participant in this process. We are really excited to have Dr. Jim Dowling, who a lot of is familiar with as a esteemed leader in our field and a huge collaborator for all of our organizations. I want to especially thank him because he literally just moments ago landed for another important meeting today, but really wanted to join. So he has now joined us. Welcome, Dr. Dowling.
Hello, can you hear me?
Yes.
All right, let me share my screen. Okay. Sorry, take 1 second. There we go. Is the audio okay?
Sounds great.
Okay. So what I thought I would do is just give an overview of where we stand in terms of understanding a bit more about the liver disease and XLMTM based on some work in animal models, and then talk a bit about future directions, and then hopefully have time for some questions. So important thing for me to note is that I'm going to be showing work that has been largely sponsored from a research perspective by Astellas. So I've had a grant and aid from them to do the work. The work is all my own and not biased or influenced by them, but they have provided research funding for it. I don't think I need to introduce this slide to the audience, but this is, I think, the launching point, which is that really prior to the Aspiro gene therapy trial, I think there was a limited understanding of liver involvement in XLMTM. Outside of the instances of hepatic ileosis that had been described, there was not much in terms of primary liver disease that was understood.
Sorry to interrupt you. I can share that we did get a chance to go into that part.
Okay. All right. So just to clarify that in the Inceptus natural history study that there was note of 90% of the patients having abnormal liver function studies. And then of course the severe fatal events of cholestasis that occurred in 4 boys treated with the AAV-based gene therapy, which obviously precipitated the question of what's going on with the liver normally in patients with XLMTM, and also why is it that gene therapy seems to be such a potentially adverse exposure. And I think everyone's probably aware that there was no really reason to predict any of this based on the really quite beautiful preclinical studies. So this is from the paper by Casey Childers and Anna Bush-Bello that was the precipitant for doing gene therapy, showing both in the mouse and the dog the effectiveness of the AAV8-based gene therapy, but also the safety. And these were really, quite elegantly done studies with, really looking for maximally at possible safety concerns. So there was no signal there. So the really question is what's going on? And how do we begin to understand this emerging liver disease when we haven't really had evidence of it in the animal models that have informed so much in other aspects of the disease? Here's where our favorite model system has hopefully helped to start pave the way. I think I've talked to this audience before a bit about our zebrafish model of MTM. So this is it here down in the bottom. This is a model where we've made a knockout mutation in the MTM1 gene to genetically phenocopy the disease in humans. And also it shares many of the muscle characteristics of the human disease in terms of the triad defects and abnormal muscle force generation. But what we noted early on is that the livers also appear abnormal. So you can see here in the red outline, this is a liver of a wild type fish. And this is the liver of an MTM fish, and it's expanded and just looks abnormal, and it's a bit more dense. When we stain this with oil red O, which highlights fat, you can see now the liver really highlighted, indicating there's a fat accumulation within the liver, consistent with what we'd call fatty liver. I think it was the first hint that maybe there's something going on in the MTM knockout livers in the zebrafish. So we then went on to look more extensively, and we did a pretty interesting assay that is the standard assay in zebrafish for looking for cholestasis. And basically what we do is we feed the fish this fluorescent dye called Bodipi, and the fish will ingest it and then metabolize it through the intestine, through the liver, and then into the gallbladder as bile. So here you can see the blue arrow pointing to a normal fish where the Bodipi has accumulated in the gallbladder. And then here is an MTM fish where none of the Bodipi gets into the gallbladder, indicating an abnormality in bile flux and consistent with zebrafish cholestasis. And we quantified this and could show that, no wild type fish would ever have this abnormality. About 80% of the MTM fish are unable to process the Bodipi into their gallbladders. Again, suggestive of a pretty penetrant abnormality in bioflux and evidence of cholestasis in the fish. We further went on to look at the bile transporters because we knew from at least the limited patient studies that bile transport expression was abnormal. And here we found pretty striking evidence that the bile transporters were dysregulated in MTM zebrafish. Probably what we think is the cause for the abnormal bile flux is the lack of these transporters in their normal location. So here's one BSEP, which was also looked at in human livers. You can see normal staining here in the wild type and almost completely absent staining in the MTM zebrafish. We did some RNA analysis, and this is a very complicated slide, but it's just to say that the liver disease in MTM looks pretty unique, with the exception that there's a very prominent immune profile, which is very typical of cholestasis. And we've now looked at another model of cholestasis in the fish and has a similar immune profile. And we think it suggests that largely the MTM livers have this prominent cholestatic phenotype, as well as a fatty liver phenotype as well. Importantly, we did an experiment where we sought to prove whether or not the abnormalities in the liver were actually directly due to MTM expressed in the liver versus perhaps MTM elsewhere in the zebrafish. And so what we did is we made transgenic zebrafish that express MTM1 only in liver, only in hepatocytes, and then cross that into our knockout fish. And what we found is that we could rescue this cholestatic phenotype solely by re-expression into the MTM hepatocytes. So largely this defect is a liver-specific defect due to loss of MTM1 in the liver. Though I will say that there are some subtleties that's not completely fixed, and that's probably because there are some contributions of MTM1 in cells other than hepatocytes that contribute to the liver disease. This fish model is ideal based on this assay that we've developed with the BODIPI for doing chemical screens to try to find compounds that may ameliorate or rescue this abnormal liver phenotype. And we performed a very targeted screen so far of compounds that we suspect or at least have been implicated in modifying muscle phenotypes in MTM. And we have had a few hits that we're now following up further on. But I think the important aspect of this slide is that it provides the springboard for doing a larger scale chemical screen to try to find drugs that can completely prevent or reverse the liver phenotype in the fish. So just to summarize this, using our previously established MTM1 deficient zebrafish, we could show that they have both fatty liver and changes consistent with cholestasis. These changes mirror at least what we suspect is happening in patients, and that seems to be a faithful model recapitulating liver disease in the zebrafish. Importantly, re-expression of MTM1 in hepatocytes rescues most aspects of the liver phenotype, suggesting that MTM1 is both necessary and sufficient to drive liver disease. And we think that MTM zebrafish are going to be an excellent model for identifying drugs to help treat the liver phenotype. One important thing to note, however, is that at this point, we haven't figured out a way to make zebrafish take up AAV. It's probably because their receptors for AAV are different than humans and mice. And so we can't really yet study that question of the synergy between liver disease and AAV that seems to be occurring in XLMTM. And that's why we wanted to revisit other models, and in particular, go back to the mouse model and see if we could understand why it didn't develop liver disease. And so what we've done now is we've used different sensitization paradigms in the standard XLMTM mouse model, the MTM1 knockout mice that Anna Bush-Bello and Josh Laporte originally established. And what we can see is that by using these sensitized paradigms, we can actually create or recapitulate pretty much all of the liver phenotypes that have been described in patients, but also that we see in the zebrafish, including this very prominent cholestatic phenotype shown here with these lab studies where we can see elevated bilirubins in the sensitized MTM mice, as well as this abnormality in transporter expression that seems to be the hallmark of the cholestatic disease in fish, mice, and humans. Also, we've taken another approach, which is to use cells derived from patients, what are called iPS cells. So these are pluripotent stem cells, which we can then turn into hepatocytes, so-called iHeps. And we've been able to successfully create these. And here are two different lines we've made with MTM1 mutations. These can form normal hepatocytes, which is not unexpected because the liver forms normally. But importantly, we find a progressive loss of the biocanaliculi in our iPS-derived hepatocytes, consistent again now with all of the phenotypes we're seeing across zebrafish, mouse, and patients. We can now add these iHeps to this model to suggest that they also show these changes. And I think this is nice because it really suggests that this is a conserved change in hepatocytes across these different models, and using human cells lends itself to more translatability to patients. We can also use these cells to confirm our findings in zebrafish and in mice, as well as use them for testing therapeutics. And that's all work that's now ongoing. So to summarize the second part, we've been able to use different sensitization protocols to reproducibly identify and study a liver phenotype within the XLMTM knockout mice. And this phenotype seems to be consistent with what we would have predicted, including both the cholestatic and fatty liver component. Importantly, with mice now, we can test this question of what happens on the sensitized background with AAV exposure. And we're actively doing that now to see if we can understand why it is that the combination of underlying liver abnormality plus AAV is causing such a severe phenotype. We also have developed what are called IHEPs from iPS cells with patient-derived mutations. And these confirm the changes we found so far and provide an excellent model system for further study. And of course, one of our big questions now is how we can treat the liver phenotype, and we're looking at that through several different angles. And just to conclude, I thought I would talk about a few future directions. So in terms of the preclinical work, and by preclinical, I'm encompassing zebrafish, mouse, iPS cells, basically everything that's not directly involving patient work. Really critically, we want to define the impact of AAV on liver disease in the XLMTM mice, and this is the experiment we're most actively doing. We also want to see if we do see that synergy, are there strategies we can use to prevent it? Because that would obviously be critical. We're exploring other therapeutic approaches for XLMTM for the liver disease and looking to see which therapies that work in the muscle might also work in liver, but also looking independently for modifiers of the liver. And we're also continuing to do studies to try to understand the why. Why is it that loss of MTM1 causes a liver phenotype? And why is it that it only causes phenotypes under certain circumstances? Can we understand what the triggers or precipitants are of cholestasis using our model systems? Clinically, I believe there's a great need to define and understand the natural history of liver disease in patients. And I think this needs to be done in a very systematic and rigorous fashion. We need to understand when patients have fatty liver and or cholestasis, what are the episodes being precipitated by, what might be helping them, and which ones are clinically impactful or actually causing symptoms to patients. And I think we've talked about with some internal discussions, some different strategies for doing this, but I really think this is a critical next piece for several reasons. One is to just be able to best care for patients in the current moment. I think we have a lot of uncertainty on what we need to do right now to help in terms of monitoring boys and men with XLMTM, and also what to do if we find abnormalities, how we think we should intervene. And then also this is critical for clarification for all future clinical trials, because obviously we're going to be very attuned to liver changes in the clinical trials, but if we don't understand when and how they occur, it's going to be very difficult to design successful trials. And finally, I think the liver might be just the tip of the iceberg to be thinking about. It's been well established that MTM1 is expressed in most, if not all, cells in the body, and the loss of MTM1 could potentially promote symptoms or changes in other organ systems other than muscle. Obviously, liver is one, and I think the evidence is now emerging quite strongly that there is a primary liver disease that occurs in XLMTM. And so the question, of course, is what other areas may be potentially affected. As a neurologist, I'm obviously very interested in the brain, and we thought that would be one area to start looking, because there is likely data that we can use that already exists to help better understand this. For the families in the audience, you probably remember that many of your children who have XLMTM may have had brain MRI scans when they are neonates. It's often part of the diagnostic workup before the diagnosis is established. And what we're hoping to do is utilize that existing data and information to try to understand whether there is a MTM specific brain phenotype based on MRI scan. So we've initiated this study, and I don't know if Joe mentioned or not, but we're doing this through the MTM CNM registry. And the hope is, again, to get some, to utilize the clinical information that's already in the registry and link it with existing brain MRI scans to see if we can start to get a better sense for if there is a specific phenotype in the brain in patients with XLMTM and what that might look like. And so I encourage everyone in the audience who either is an individual with XLMTM or as a family member to think about participating in this study. We're doing it through clinicians because we will need to access the records in order to get MRI scans. And we want to primarily view the MRIs because we think that's going to be critical for the success of the study. So I'm going to stop there, and I'm very happy to take questions. I want to stop sharing my screen. give it up.
So thank you so much, Dr. Dowling. We so appreciate you participating, especially in the midst of traveling for an important meeting. But also, I want to call people's attention that we're really grateful for not only your leadership in terms of clinical information and care, but also the research, and in addition to the contributions you make in your leadership role with Treat NMD as president, and just being in touch with the whole entire field of neuromuscular care and rare disease, and really helping to champion the importance of patient engagement and coming together, sharing data, and all of those important things. So thank you for that, all of that. We are, incredibly running over on time, and we appreciate everyone's patience. I think I was getting some text that maybe our best way to move forward, unless there's I don't see a specific question yet come in for Dr. Dowling, but I want to assure everyone that we will curate all of the questions that have come in, and we can do like we have with similar webinars and work together to get responses from our group here. I did see one question that I want to call attention to, because it is some of our next steps as a liver working group, is to come up with a one-page summary that you can easily bring to your care team to talk about things that the way you might want to integrate your care to now have a better surveillance of liver issues, and also to inform them of the liver questionnaire that is being conducted, so that they can help you in filling out that information to participate. That's also something you can also individually do without your physician, but I did see that as a question and wanted to address that. That is something that we acknowledge is something that could be incredibly helpful, and we plan to work on that as a next task for our group. Anything else? I just want to thank everybody for joining us, for the time and dedication. I'm incredibly thrilled that everybody that wanted to participate today in speaking was somehow miraculously able to be a part of this, even coming in through travel. So we appreciate the professionals' time and energy and dedication to this community and helping us to sort out these evolving issues with liver. Here are, like we said, although the trust, Myotube with the Trust, our organization, MTM CNM Family Connection, and the MTM CNM Patient Registry were hosting this event, we couldn't do it without the help of all the members of the Liver Collaborative that we've been working closely with. And again, if you're interested in learning more, please just email MTM CNM Family Connection or the Myotube with the Trust for more information. And I'm just going to open the line for a minute if anyone has any final word. Ian or Joe?
Erin, can I just say one thing about the translations for the registry questions? As Joe said, if you're a native speaker of any of the languages she listed, if you could help us with translating them, that would be fantastic. And they've already been run through a machine translation. So the job isn't huge. It's a proofing job to check whether the machine translation's gone okay. So any volunteers that could help us with that would be really great. Thank you.
And I just want to add that it's very normal to ask your clinician for a report of genetic testing or other tests which have been performed. So don't hesitate to do that.
That's a really good point, Nicole, because a lot of places now we have online portals, but if there's places that it's harder to get your own data that is your patient data. So like Nicole said, that's something that you can request from your care team.
And especially if gene testing has been performed a few years ago, it might not be part of the electronic patient file. It might be still somewhere else.
Very good point. Joe, any final word?
No, nothing from me. Just thank you for listening, and hopefully we'll see lots of nice data coming in. We are also planning to present the first 6 months of data collection at the World Muscle Society conference in October, so don't delay.
And we understand that some of this information could be, we wanted to arm you with the information that is currently available. Understand that there's still so much more to learn about that we can do together both professionals and the family members, and industry partnering together as well. So that's what we were hoping to deliver today. Obviously, there is so much more to be shared. So this will not be our last webinar on this topic, I'm sure. And we will continue to hear about the needs in the community and try to be responsive to them. So thank you much for everyone's time and energy, and we really appreciate it. Everyone be well. Thank you.
Thank you.